Thank you so much for that generous introduction. And thank you all for joining us. And I'm also very grateful for the invitation and for sharing this panel with this distinguished list of presenters and speakers. So my conversation today is, whose prevention is this? And as we go through our slides, you actually could put different emphasis on the different words in that question. It could be, whose prevention is this? It could be, whose prevention is this? And at some point, you might even find yourself applying this one. Whose prevention is this? But bottom line is, we're talking about centering women, girls, femmes, and gender expansive people who've been assigned female at birth in the fight to end HIV. So what I want to do a little bit in this conversation is have a Sankofa moment, and I'll explain and describe what Sankofa is in just a moment, give you a bit of a snapshot of the data specifically on women and HIV in the US, because that is primarily where we're doing our work. And there's so much about our work that holds implications for women around the world. And I also, without apology and without any reason to defend it, will have a keen focus and emphasis on women of African descent in the US and worldwide. Want to talk from a prevention standpoint of what's old and what's new in the science, as it were, what's possible in terms of what the future of prevention looks like for, especially for women and girls and gender expansive identities, or women in all of our identities, as you would say, and diversities. And what is my organization's response? What are some of the creative innovations that we're engaging in? And then, of course, I wouldn't be me if I didn't close on the argument around why women, and why we know for sure that there is no end to HIV without women. So the first thing is, each month I try and come up with, what am I trying to learn this month? And this month it's Sankofa Frames My Future. It's also my birthday month, so it's always a moment, a special moment to have a reflection. But Sankofa is a West African, actually it's a Ghanaian term that comes from the Adinkra symbols, which is a part of the language. And this is a particular Adinkra symbol that says it's okay to go back and get what you left behind. It's okay to look back to your history so that you know where you are, and even more important, where you're going. And that's a little bit of what I'm doing this month for myself in my new birth year, or my next birth year, but also what we're doing in terms of our work. So let's talk about the fact that almost from the very beginning, worldwide, women are half the HIV/AIDS epidemic. And we've actually ticked up. And when you begin to include women in all of our diversities, we are well more than that means, including, of course, transgender individuals. We are way more than half of the epidemic at this point. And the truth of the matter is that we have always been fighting for inclusion, whether it be in identification, whether it be in epidemiology or surveillance, and even in treatment, prevention, care, research. It doesn't matter. We've always been fighting for a place in the HIV response, from leadership to experience. We have been here from the beginning, quiet as it's been kept. Women didn't just come into the movement years later. We've been here from day one, fighting to include the conditions that are specific and responsive to the HIV infection in women's bodies, particularly things like cervical cancer and other gender-related and reproductive-related conditions that HIV renders problematic as an opportunistic infection in women. And the movement to change the epidemic, change the definition of HIV and AIDS in the epidemic, was led by women of color living with HIV. That history should never be forgotten. And so while we have always been here, best believe that even in today's day of the science and the technology and the new news, if it were, we are still here fighting for that same inclusion. So I say all of that because we have an ongoing problem with a disparity in HIV infection among women and adolescents, or female adults and adolescents in the US. And in this particular set of slides or data coming from the Centers for Disease Control, we are talking about cisgender women in particular. So as you can see, this is what it looks like in the United States across the southern region where most of the epidemic is, as well as where most of the Black people are, and in large instances where most of the women are in the United States living with HIV. I live in the state of Georgia, where you can see we are amongst the darker colors across the southern region, and there are plenty of reasons for that. But even more disturbing is when you break it down by race and ethnicity. Of course, women of African descent are still representative of a disproportion of the epidemic, regardless of our smaller representation of the overall population of women in the United States. However, we have seen a decline in new HIV infections in women of color, particularly African American and Latina or Latinx people. And what is noticeable is that there's a small uptake, significant enough though, in white women in the United States. And that is almost all solely attributed to, that is almost completely attributed to the opioid crisis, the opioid epidemic that we have in our country. There's also been an uptake, a very slight uptake in Native American and in Latina or Hispanic women. There's also some good news, and I want to make sure we keep this going, because when we get to the conversation around PrEP, what's really important to recognize is that women actually were a part of the very first pre-exposure prophylaxis studies that have ever been done in HIV. And that was with regard to protecting women who are pregnant or people who are pregnant from giving birth to infants that were exposed to HIV and then living with HIV. And as you can see here, what's most important in this story is that before pregnancy, and this is in a number of about 200 infants who were exposed and infected. Before pregnancy, about 47% of these are maternal HIV test results. And you see about 47% of those pregnancies had infants who were actually infected, but 81% overall were those who were exposed but not infected. And that means that's the good news, given that we have probably about 12,000, close to 12,000 exposures. We have only 200 infections. That's actually really, really important news. And that's all. This is also the future story of HIV, especially among women, and the cause for prevention. And that is the number of those persons who are living with HIV who were exposed to HIV perinatally and were born living with HIV. That too is a number of about 12,000. And I consider this the future because of all the women that we serve in our community who are born living with HIV. They call themselves verticals in terms of vertical transmission. That of all of them, nearly 100% of them are virally suppressed. That is the future of HIV prevention. Now, here's the other part that is problematic. And this is where I say, you know, people, we have a problem in terms of the uptake of what's available to us in terms of the science. There's a prediction of about close to 1 million men and close to 230,000 women who have indications, PrEP indications, meaning that there are different modes of transmission for which they have increased opportunity or increased chance to be exposed to HIV and or to become infected with HIV. And what's dismal about this data is that the uptake in the people who need it the most is still slagging or lagging behind in terms of uptake. Here we have a very low level, and these numbers have dwindled, not increased, in the last few years since the beginning of oral PrEP, which up until recently has been the only biomedical form of HIV prevention available to us, post condoms and that sort of thing. But in terms of women and people of African descent or Black folk in the United States, you can see that we have expressions of greater indications for need with PrEP, but we also have the lowest amount of uptake across the country and across populations. So the problem is that while 23% of the people who are eligible for PrEP, eligible basically meaning that had indications for PrEP, were actually prescribed PrEP 3 years ago. And that number, of course, coronavirus notwithstanding, that number has dwindled as well. And we can explore some of the reasons why. And there are some things that women just said, nah, I don't think so. Why? Mostly because they thought they were okay with using condoms, and they had been encouraged and inspired by the information that was shared with them at the time that they could use condoms more often, that they were inspired to do that. They also didn't see why they needed to take medication every day for a prevention formula or prevention practice. And they were concerned about how it would be paid for. But most importantly, overall, the bottom line decision was weighing all of these different considerations. Most people did not feel that their sexual behavior was risky enough or substantial enough for daily medication. And that, we think, is where part of the problem lies in how we talk about why these things are important. Is it because we talk about risk? Or is it because if we centered the question about HIV prevention on things that really matter to the women that we serve, at least, we actually get different answers about what's important to them. And risk is not usually the first thing on their list. So when we're talking about one of the things that is on their list is that there's so few options for them. So not everybody is going to be poised to take a pill every day. There are those for whom they believe in it and it works. And for a lot of us, we already take a lot of other things every day anyway. And adding, especially those of us who are bent on our vitamins and supplements and preventive solutions, that this becomes another preventive solution. Taking a pill doesn't matter to them, but for others, it's really deeply concerning and they're not really interested. So why not increase the options? Well, we have new news now. We now have what's called a long-acting injectable. I would argue on a whole nother day that long-acting is not really what we're talking about here, especially from the women's concern, because contraceptives that are long-acting last way longer than 2 months, which is the current frequency of the need for the what's now called Aperture, or the cabotegravir long-acting injectable for PrEP or for prevention. And so the reality is that having 2 options is now available to us, but there are still some deep concerns about how that's marketed. So we'll pay attention to those things, because I'm not going to call these long-acting injectables so as to not confuse the populations we serve, who understand long-acting to be very different over a 60-year history of contraception. So here's the future of PrEP, and this is why the options matter. Not only are we currently looking at studies that include subcutaneous injections, so there are more shots coming that are less that are hopefully coming that are less frequent, but we're also looking at different ways to inject. So there's the current every 2 months or every 8 weeks. We also have recently, at least in 2 countries, approved the dapivirine ring for PrEP, at least I think in Zimbabwe and South Africa most recently. The dapivirine ring has been approved, while disappointingly, the FDA is not going to be considering the dapivirine ring for distribution or accessibility for women in the United States. So we also have the broadly neutralizing antibodies, which is still undergoing really sensitive clinical trials. And that would be an injection every 2 months. There's a new form of oral PrEP, which would come in maybe once a month or maybe once a year, should these drugs show any efficacy. And then there are other methodologies in the pipeline, things like the same options we would look for contraception or for planning pregnancies. We want some of the topical solutions still. We still want gels. We still want multi-purpose technologies. We want things that are going to prevent pregnancy as well as preventing HIV and possibly other STIs. I'm always the one to say that, you know, when you go into a drugstore and you look down, or into a pharmacy or a chemist, and you look down the many aisles of things in the beauty and health section, there's aisles and aisles of products for your hair. There's aisles and aisles of products for your face or for your fingernails or toenails even. What I want is as many options for my reproductive organs and my sexual organs as I have for my hair and my face, simply put. That's what having more options means. And of course, when it comes to how the Centers for Disease Control in the United States looks at ending the epidemic, first, of course, we have to diagnose everyone who is living with HIV as soon as possible and get them into treatment. And then, of course, preventing new infections or new transmissions by using the proven interventions we have. That still includes social and behavioral and structural interventions, as well as biomedical interventions like pre-exposure prophylaxis, post-exposure prophylaxis, and or other harm reduction services like syringe exchange. And of course, we have to be able at a population level to respond to outbreaks as soon as we hear about them. For example, the latest news about the discovery of a new and possibly more virulent strain of HIV in Europe, in Western Europe. So several years ago, several years ago, SisterLove took on the attitude that we cannot treat people differently. When we're serving women, we understand that women live the same lives. There are those who can talk about the same lived experiences before their HIV diagnosis with women who are not yet HIV diagnosed and have the same lived experiences. So we can't treat people differently except for what their HIV result, their test result tells us. And so we took on an initiative that we call TLC for All, or Testing and Linkage to Care for All. Where we've ended up is now with a national approach called status neutral, which basically means that regardless of someone's HIV test outcomes, that we have a pathway that is cyclical that ensures that they have a way to preventing HIV, whether through viral suppression, if they are living with HIV, or through pre-exposure prophylaxis or other prevention intervention means. In order to get all of these things out into community, as well as they say, into people's bodies, we need to make sure that we're implementing advocacy and that we're doing so especially with young women. And some of that advocacy for us at SisterLove is about sexual and reproductive justice, which goes beyond the context of sexual and reproductive health and rights, because health and rights is about service delivery and about protections under the law. Justice is about equity. It is about being able to work across the intersections of someone's life so that their choices around having children, not having children, parenting their children, making the decisions they need to make about their own bodies, about their own well-being, about their own sex and their own sexuality is all concomitant to us ending HIV. And intersectionality is the required root that was initially coined by Kimberly Crenshaw. And Attorney Crenshaw, who is a legal scholar teaching in both two law schools, basically identifies intersectionality as the lived experiences of people for whom there are multiple oppressions, which means that there are multiple experiences and marginalized expressions of those experiences throughout society. And that intersectionality requires that we look at social determinants in a very, very different way. So if we're talking about social determinants of health, which is an intersectional framework, by the way, that takes a look at all of these different kinds of experiences, what I would argue is that these are not all social. So they're not necessarily social determinants of health, but they are determinants of health inequity. And that one way we can change the trajectory or the paradigm is to make sure we're distinguishing them, because the response to them is different. Are they fixed determinants? My race is fixed. My gender is fixed. My sex, should I choose to go with what I was assigned at birth, is fixed. And once I have reassigned, that is fixed. But how I'm treated based on those distinctions is what can be considered a social determinant. And the way things are arranged to make sure that people have equal access or coverage or quality, it becomes decisional by people in privileged spaces to make decisions, and that makes it political. How we define these determinants also defines how we respond to them. And of course, if you sprinkle a little sex and gender on top of that, that also changes the paradigm of how we think about social determinants, because now we begin to think about human rights. And we also have to engage community at every level, from beginning to the very end, with ideas and lived experience being used as what I call indigenous expertise, or what others might call data. So I'm going to close on this, and I know I'm a little over time. I'm going to close with the fact that, most importantly, where we are challenged, I believe, with PrEP and women these days is the language of risk, one, and two, the language of PrEP in and of itself. U equals U, undetectable and equals untransmittable, is the community translation of what we know as HPT and 052, or treatment as prevention. It is the study that showed us that reaching and achieving and sustaining viral suppression means that a person living with HIV is no longer capable of transmitting HIV. Making it simple and usable because it speaks to a story in my life, U equals U is working. Pre-exposure prophylaxis is a scientific term that is in no one's everyday vernacular. It is in no one's everyday lived experience, and it is not in everyone's everyday understanding of what it means to prevent HIV. PrEP, I think, is problematic, and that we need to come up with terminology that actually people can identify their own lived experience in their own stories. There are women who speak to this. From risk to reasons is the new paradigm, one that is being put forth right now by one of our HIV-specific pharmaceuticals. This is a campaign that is just now being released.
I believe that we need to reframe HIV risk, because Black women speak and hear messages differently from everybody that's not a Black woman.
Because risk implies shame and blame, and no one should feel shame and blame for being an active participant in their sexual or reproductive health.
Reframing HIV risk has to be normalized to end stigma.
Because my intimacy and my pleasure, that's not a risk.
I want HIV prevention for Black women to be led by Black women, because no one takes care of us like we take care of us.
Comprehensive, relatable, non-judgmental, and free.
So that each and every Black woman receives the messages in ways that she understands.
No shame, no judgment for taking control of our sexual health.
That's my reason.
That's my reason.
That's my reason.
And with that, I'm going to close with reminding you that we have been here and we will be here until it's over. Thank you.